So we just talked about a zillion muscles, and we haven't even got to the, we're just now getting to the glenohumeral joint. So the glenohumeral joint, a lot of times when we talk about shoulder problems and shoulder things, it's almost synonymous with the glenohumeral joint, even though we know that the shoulder involves more than just the glenohumeral joint. The really, shoulder movement is a combination of glenohumeral movement, scapulothoracic movement, acromioclavicular movement, and sternoclavicular movement. So all four of those joints are involved in what we consider shoulder movement. So the motion of the scapula is particularly important to glenohumeral movement. As we talked about scapulohumeral rhythm, we will talk about it again. And it's important to the function of the abduction and elevation muscles. So there's a lot going on in the shoulder. It's not just the glenohumeral joint. Even though when we talk about a total shoulder replacement, we're replacing the head of the humerus and the glenoid fossa. We're not replacing the scapula or the acromioclavicular joint or anything like that. So even though the glenohumeral joint is not all there is to it when the shoulder, there's a lot going on in the glenohumeral joint. So let's talk about it. So of course we want to identify all the attributes of the muscles. We start to get into some muscles that can have passive or active insufficiency. It's much more common in the lower extremity than in the upper extremity, but it's possible in the upper extremity with some of the multi-joint muscles. So we're going to talk about basically abductors and flexors. So abduction is frontal plane movement, flexion is sagittal plane movement, and the two of them together can be thought of as elevation of the upper extremity. So besides the frontal plane movement of abduction and the sagittal plane movement of shoulder flexion, we've got this room in between. So there is a plane that is parallel to the scapula. That's an oblique plane. It's not one of the cardinal planes, and it's called scaption. So scaption is halfway in between flexion and abduction, if you want to think of it that way. A lot of times when people are recovering their motion after an injury, flexion is difficult, abduction is more difficult, but scaption, which is a more functional motion, by the way, is more doable. So all of the muscles that perform abduction and flexion also are involved in scaption, and a lot of times that's where we start when we're trying to recover motion. So the abductors, and we'll go through all the details for all these, are primarily the supraspinatus, which is also one of the rotator cuff muscles, and the anterior and middle deltoid. The flexors are the anterior deltoid, the clavicular head of the pectoralis major, the coracobrachialis, which is an assister at best and a stabilizer for the most part, and the biceps brachii, which also has a big function at the elbow. And we'll talk more about that in the next chapter. So the supraspinatus, it lies under the acromial arch. So it runs through the little tunnel under the acromial arch. And it's also deep to the trapezius and the deltoid. So it's that deep muscle. It runs in that supraspinous fossa of the scapula. That's its origin. It's the bed of the supraspinous fossa. And it goes out and inserts on the greater tubercle of the humerus. I had to go get my humerus. So the greater tubercle is the more lateral of the two big bumps. So the lesser tubercle is the more anterior. Then we have the bicipital groove or intertubercular groove. And the greater tubercle is this big lateral bump on the edge of the scapula. You can think of it as being somewhat analogous to the greater trochanter on the femur. Of course, the humerus is a little different from the femur, but similar in some ways, different in others. So the supraspinatus is running right along, has that straight lateral line of pull for shoulder abduction. it gets the suprascapular nerve. So it's at the top of the scapula, suprascapular nerve. That makes sense, doesn't it? Supraspinous fossa, supraspinatus, suprascapular nerve. Okay, so I'm trying to help remember that. So it has that beautiful line of pull for abduction, straight out line of pull, really nice. A lot of, it's not uncommon to get supraspinatus strains, and that makes abduction difficult. The anterior deltoid, it assists the middle deltoid with abduction. The deltoid is, not surprising from its name, a triangular muscle. It has a broad attachment along the clavicle and scapula, and it tapers down to a small attachment on the deltoid tuberosity. So the anterior deltoid goes on the anterolateral third of the clavicle. The middle deltoid keeps going around the corner, and then the posterior deltoid is on the spine of the scapula. So it kind of frames that little arch going around the acromion, from the clavicle to the acromion. So all three heads of the deltoid. The main job of the anterior deltoid is flexion. It's got those anterior to the medial lateral access fibers, and so when they contract, you get flexion. It also does medial rotation because it has a little bit of a lateral pull, so medial to lateral, and does medial rotation. And then horizontal adduction, which is something that only the shoulder does, has that line of pull. But we're talking about flexion right now. All of the heads of the deltoid get the axillary nerve. So you can think the axillary nerve is like armpit, axilla, right there by the deltoid. It's innervated by the axillary nerve. So the middle deltoid, its origin is the superior lateral surface of the acromion process. So just that nice little shelf that we carry a purse or a backpack on. And its insertion is the deltoid tuberosity. So the deltoid tuberosity is the insertion for all of the heads of the deltoid. Its job is abduction. That's what it can do. Axillary nerve, it has that nice straight line of pull from the acromion process to the deltoid tuberosity. Nice medial lateral movement. It's lateral to the anterior posterior axis, and so it performs abduction. It has what's known as the inchworm effect. So as you abduct, the deltoid gets shorter and shorter, and then the scapula rotates up to move the acromion away from the insertion, restoring the contractile potential of those actin and myosin fibers. So they contract, 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 and then the scapula moves, gives them more room to contract. They contract, contract, contract. The scapula moves. So the inchworm effect is closely related to scapulohumeral rhythm, because for every 1 degree for every 2 degrees of glenohumeral elevation, you get 1 degree of scapular upward rotation. So you get that nice motion. So the inchworm effect is important for restoring contractility to the middle deltoid. Okay. So the clavicular head of the pec major, surprise, surprise, attaches to the clavicle. That the name just gives it to you. It's superficial. It forms the axillary fold, like the front of your armpit, if you want to think of it that way. That's what it is, axillary fold, front of your armpit. The pec major altogether is a big triangular muscle with a big, broad, sweeping attachment with lots of different fiber directions down to a small insertion at the crest of the greater tubercle of the humerus. So the crest is the edge, like you're on the crest of a hill. So the clavicular portion goes from, it's pretty horizontal from the clavicle to the greater tubercle of the humerus. So it does shoulder flexion up to 90 degrees. Once you get past 90 degrees, the clavicular portion of the pec major doesn't really have a line of pull for flexion at that point. You're changing the geometry, so we have to depend on the anterior deltoid at that point. It also does medial rotation. You can see how if it pulls the greater tubercle anteriorly, you're going to medially rotate the humerus, and it does horizontal adduction. Has a perfect line of pull for that. So think of doing your chest flies, your pec major, the clavicular head is doing a lot of it. It gets the lateral and medial pectoral nerve just like the pec minor does. So the biceps brachii, they're elbow flexors, like it says on the slide, but they're also shoulder flexors because they cross the shoulder and they cross the elbow. So it has two heads. We'll talk about the corkscrew effect for supination when we get to the elbow. But the long head of the biceps attaches to the supraglenoid tubercle. It goes through the bicipital groove in between the two tubercles, or the intertubercular groove, and it attaches to the superior supraglenoid tubercle. The short head attaches to the coracoid process, which is also on the scapula. So the superior insertions, or the origins of both heads of the biceps, are on the scapula. And then the distal insertion, they're both on the radius. So they're on the bicipital tuberosity of the radius, also known as the radial tuberosity. So even though it has a huge effect on the humerus, it doesn't actually attach anywhere on the humerus. Pretty interesting, right? So it assists in shoulder flexion. It's not its main job. It's moonlighting on shoulder flexion. But because it has that shoulder flexion component, there's a potential for active or passive insufficiency of the biceps. So we'll talk about that when we get to the elbow. It's innervated by the musculocutaneous nerve, and the musculocutaneous nerve innervates most of the elbow flexors. That will come into play when we get to the next chapter. The coracobrachialis, I don't even have a picture of it. It goes from the coracoid process to the medial surface of the proximal humerus. It barely has a line of pull for flexion. It's more of a stabilizer. It stabilizes the head of the humerus against the glenoid fossa. So maybe it does flexion, but it's more of a stabilizer than anything. And it gets the musculocutaneous nerve. So it's sort of like the biceps little helper, if you want to think of it that way, and mostly for stabilizing the shoulder.